Like Sharon said, I'll be talking about Medicare's pay-for-performance programs and how mechanism design can kind of help with optimizing them. And this is joint work with Mohsen Bayati and Ramesh Tiwari, who are at Stanford, Mark Robertman, who's at Princeton, and Ramki Gulani, who is at Facebook. Okay. So as you all know, healthcare costs are on the rise, as you've probably seen in the news. Last I checked, we had spending over $2.5 trillion a year, which makes up over 17% of the GDP. And this is by far the highest per capita healthcare spending of any country. And about half of this is just government spending alone through Medicare and Medicaid programs. So we still have poor quality and outcomes, even though we spend so much more per person in this country. So there's always the big question of why and what can we do to fix this. I didn't do research in that, but a lot of experts have looked at it. And one of the key reasons that they claim is distorted incentives that arise from misaligned payment systems. So what does that mean? One of the big issues in healthcare is that we have information asymmetry. So you have an insurer or Medicare that's reimbursing a provider or a hospital for providing treatment to a patient because the insurer or the payer doesn't know what the right treatment is for the patient. So now they're relying on the doctor to make the best choice. But the best choice for the doctor is not going to be the best choice for the insurer. So as an example, this is a story from a recent Economist article, and there's lots and lots of these examples. When a doctor treats a patient enrolled in Medicare for breast cancer, he may prescribe paclitaxel, a treatment costing the government $201 and netting the doctor $12 in profit. Or he may prescribe a comparable treatment, Abraxane, costing the government a whacking $16,700, but netting the doctor $1,000. So I think in this example, it's kind of obvious that there's an incentive misalignment, right? So for the patient, we're assuming that both treatments are kind of similar, but one treatment is definitely way better for Medicare because it's way cheaper. And then one treatment is better for the doctor because it gives them a much higher profit margin. And the interesting thing is neither the doctor or the insurer are the ones that are making a ton of money out of this transaction. It's actually the pharma company that's selling Abraxane. So this clearly creates some kind of inefficiency in these contracts. And the reason that this happens is because, at least until recently, Medicare payments where if you prescribed a drug to a patient, the doctor would be reimbursed based on the prescription cost plus a 6% premium. So that clearly incentivizes them because it's a percentage to prescribe kind of more expensive drugs, which is not what Medicare wants. So this is something that you could look at this and say, all right, I'm going to fix this. But the healthcare payment policy is plagued with these kinds of issues. We can't reasonably go and fix them one by one. Questions about this? All right, so how do we solve this? A lot of pushback has come from saying we should not have flat payments, but we should start adopting pay-for-performance programs. So pay-for-performance programs basically say that instead of paying a hospital for a particular patient at a flat rate, we should actually tie the amount of the payment to the patient outcome or the kind of value that they produced. So if you spend less or if the patient does better, then you would actually get more money. So more than half of commercial HMOs have adopted these programs, and the Department of Health and Human Services has committed to tying 90% of all traditional Medicare payments to quality or value by the end of this year. So we'll see if that happens. But unfortunately, there's not a lot of guidelines about how to think about designing these pay-for-performance policies. So there's a big econ literature on contract theory, but that doesn't necessarily apply to these healthcare policies because there's a lot of institutional constraints, like we'll discuss in a bit. And basically Medicare and like a bunch of stakeholders get in a room and they hash out what are kind of acceptable policies to them. They can't necessarily follow the guidelines in contract theory. So because of that, the resulting policies have been extremely ad hoc. And worse than that, maybe because of that, there's a huge variety of them in practice. So if you look at any particular policy, we'll have a different structure and a different functional form. And there's always lots and lots of studies in the Agency of Healthcare Research and Quality talking about, was this the right way to structure this? How should we have picked the policy? which begs the question, how should we be designing these policies? Can we say anything about what kinds of structural or functional forms would be best in terms of getting the desired results? So recently, Medicare has implemented 3 pay-for-performance policies for hospitals. So these are all targeting the kind of same group of hospitals. And the first one is called value-based purchasing, which tries to get hospitals to reduce the amount of money that they're spending per patient. So that's why it's about value. And the next 2 are really about patient outcomes. One seeks to reduce hospital patient readmissions, so how many patients come back within 30 days. And another one seeks to reduce hospital-acquired conditions, which are things like hospital-acquired infections. Maybe there's an object left behind after surgery, and things that really shouldn't happen like that. Adverse events in some sense. So these 3 policies came out around the same time a few years ago, and they're all similar philosophically in that they all modify the traditional fee-for-service. So fee-for-service is how payments are usually made, which is per diagnosis for a patient. Right? So you have pneumonia and I pay you a flat rate. And they're modifying that by adding a small performance-based incentive. Right? So now they're trying to, each of these programs is trying to tie the payment to either the cost of the treatment or the value for the patient in terms of outcomes. And these 2 programs are very similar in that for each of these performance-based modifiers, they're capped at 1 to 3% of the base payment. So technically, they're pay-for-performance policies, but largely they're still not, because most of the payment is still a flat rate. But a small amount of it is tied to either the cost or the patient outcome. And I should mention that even though these 3 programs kind of have the same intended consequence and are targeting the same hospitals and are by Medicare, they're all completely different. Like later when we see the functional forms, they'll be totally different, which goes back to the point I was saying that they're very ad hoc and there's a huge variety of them. Okay, so there have been questions about is this performance-based payment too small? Right? So you're saying you're doing pay for performance, but if it's only 1 to 3% of the payment, is that really pay for performance? Medicare's argument is hospitals are low-margin firms, so if we start making the performance-based modifier too large, then we might drive hospitals out of business. There would be large variance, and this would be unacceptable to the stakeholders. But a lot of medical articles have been written about saying, well, if it's too small, then does it even offset the provider's cost of improving quality or reducing costs? Is this even worth their time to try to satisfy? It doesn't matter. Medicare has not budged on this topic, so they're keeping the incentive size extremely small. And in terms of empirical evidence, it's not really sure what's going on, because if you look at past studies or past pay-for-performance programs, even a very small pay-for-performance program has had a history of having a huge impact, and even large ones sometimes have had no impact. Okay. So it's unclear whether the incentive size should be large or not. And I think one would actually need to do a careful study of all the costs and stuff to be able to say. So that motivated our question, which is, can we look at this game theoretically to provide another lens into how these policies should be designed, when we should have pay for performance, and so on. Questions so far? Okay, so just to quickly overview the talk. So first we'll start off by analyzing a very general class of pay-for-performance mechanisms under the principal agent model. So principal agent model is one of the most classic ways in econ to analyze these types of problems. And a key feature of our model is that these incentives have to be small, because Medicare is only interested in focusing on small incentives. And typically people look at linear contracts or contracts that have some kind of nice, smooth, functional form. We're not going to do that because, as you'll see, Medicare's policies are highly non-smooth because they're fairly ad hoc. And so we'll look at a very general class of policies, and then we'll look at a restricted model. And that'll give us some rule of thumb about how to choose the design of the pay-for-performance program. And I'll show you some insights that we get about existing policies. And then we're going to take a step back and say, all right, if I were to forget about all these institutional constraints and try to actually derive an optimal contract, what would that look like? And that'll give us some insight about when these mechanisms are even useful, should we even bother with pay for performance, and how big should they be? So very briefly about related literature, there's a lot of work in econ and contract theory about principal-agent models. I'm not even going to try to go over that. There's less work on healthcare contract design. So people have looked at things like what happens when there's no asymmetric information, or how can we provide reputation scores for providers to help better assign patients. People have looked at possible collusion between referrals and general physicians, and how you can try to design contracts to mitigate that, bundled payments, and so on. We're really related to the last bullet, where we're looking at these Medicare policies and thinking about the size of the incentive. So Zhang et al. Basically do an empirical study where they show that having these small incentives is really not great because it only incentivizes some providers and not others, which is kind of goes back to the pushback from the medical community, but Medicare is not, kind of budging on that. And Aswani et al. Has this paper on using inverse optimization to try to figure out how to design these contracts. So we're closest to them in the sense that we're also trying to add input about how to design these contracts, but their main recommendation is that the size should be bigger. We're saying, we're taking the opposite approach where we say, all right, give us all your constraints, give us your feasible set, and then we'll try to say something useful beyond that. Questions? Okay, so then let me introduce the model. So we'll have patients indexed by T who are arriving sequentially to see the provider. Right? So this is a principal agent model. So the principal here is the insurer or Medicare, and the agent is going to be the provider or the doctor who's actually giving the treatment. Right? So we're going to index each patient by their features. So XT is kind of everything that will determine what the right treatment for them is. And there's asymmetric information, which we're going to capture by bucketing these features. So we have X1T and X2T. So X1T is the set of information about the patient that everyone observes. So the insurer sees it as well as the doctor. This could be things like age, their past diagnoses, their past medications. So even Medicare knows quite a bit about the patient before they even walk into the doctor's office. And then X2T captures the information that only the physician or the provider knows. So this is information about their current symptoms, whether they actually need the expensive treatment or not, whether they actually need that MRI or not, and things that are not observable by Medicare. If not, they would actually, efficiently allocate those things. Okay. So this really captures the information asymmetry. And then the physician or the provider or the agent has access to one of n possible treatments. And each of these treatments is indexed by two vectors, beta I and AI. And they show up in the utility functions. So the principal's utility will model as X transpose beta I if patient with features X is given treatment I. Right. So this is a nice way to model this because it captures both patient-specific effects through X and treatment-specific effects through beta I and the interaction of them. Right? So the principal's utility is really kind of the cost of the treatment plus the outcome of the patient. So it also depends on patient characteristics as well as whether that treatment was really effective for that patient. Right? Does that make sense? Okay. Then the agent's utility, we're going to say, is rho times X transpose beta I plus X transpose AI, which is the other vector. So the first term captures how much the physician or the provider cares about the principal's utility. So the doctor themselves might care about Medicare's utility indirectly because they care about the patient's welfare. They also care about their own reputation, so word can get out and things like that. And they might just generally be altruistic. But then the second term captures kind of their private preferences about the treatment profits, which we don't know. Like if Medicare had known that Abraxane was much more profitable, then that would go into kind of the shock term and they would have made sure that didn't get prescribed. And then there's also things like patient-specific effort. So sometimes a particular treatment is much harder to administer on one patient compared to another. They might have different insurance policies and so on. So these shocks are captured, again, they're capturing both treatment-specific factors as well as patient-specific factors through the X and the A. Does that make sense? Okay, cool. So the fact that there's two groups of covariates, both in the patient factor features as well as the treatment features, kind of captures the information asymmetry, right? If Medicare observed both sets of information, then they would just be able to pick the right treatment, but they can't because the doctor observes things that they don't see. And just for analytical tractability, we're going to assume various distributions for these vectors. So we'll say one is drawn from a sphere and the others are drawn from a multivariate Gaussian. Okay, cool. And then the other part of the model is adding this pay-for-performance incentive, right? So the agent, and as is always the case in principal agent models, they're going to choose the treatment that maximizes their utility, right? So the physician is going to choose Abraxane if they're going to make much more money doing that. So we want to offer a pay-for-performance incentive fee, and fee is going to depend on kind of the end performance, so whatever, either the cost or the patient outcome that they observe. And obviously, we want it to be non-decreasing in that performance. So if you do better, then you should get a bigger incentive. And its magnitude is going to be characterized by epsilon. So like I mentioned, we were going to look at small incentives. So we'll be taking this limit to 0. So now we can modify the utility functions by basically just taking what we had before and subtracting out fee for the principal and adding fee for the agent. Okay. So basically, this is just a transfer. Medicare is going to pay some amount to the physician to try to get them to do what is best for the insurer. Okay. And the goal is to choose a mechanism fee that kind of maximizes the principal's expected utility. Okay. Okay. That's the model. Any concerns? Okay, so I'm going to talk about two results. One is a very simple result that'll give us immediate insights for Medicare. So here we'll assume that the incentive size is very small, and we'll look at just two treatments and where the agent and principal's correlation rho is actually just 0. Right? This will give us kind of a very simple, straightforward rule of thumb to analyze, and this will tell us about existing policies. And then I'll talk about optimal mechanisms without these constraints. So first, this is the rule of thumb I was mentioning. You can show that one mechanism is better than another mechanism if and only if G of phi 1 is bigger than G of phi 2. So what's G of phi? It's just two terms. One is the expected utility from the agent switching their action. So obviously, if I offer a larger incentive, I'm more likely to get them to do what is better for me. But on the other hand, then obviously I'll have to pay the cost for giving them the larger incentive. So it's really about this trade-off. Okay. So tau is kind of the magnitude of the agent's preferences. Right? So I'll get to that in a bit. So this immediately gives us a corollary about when we should even have this kind of a pay-for-performance program. It turns out that it's better to have a policy than to not have a policy when M, which is the ratio between tau and sigma, is small. Okay, so what's tau and what's sigma? Tau is the variance or the magnitude of the agent's preferences. So if we go back to the economist example, for the physician, choosing between the two treatments was a difference in reimbursement of $12 and $201. So tau squared is kind of the variance between those values. So here that would be kind of small. And then sigma is the variance in the principal's preferences. So for them, the difference between those treatments is almost $17,000 versus $1,000, so it's way larger. So in this case, it actually makes sense that a pay-for-performance policy could work really well, because I could have paid the physician $200 more to prescribe the cheaper treatment, right? And that would have saved me about $15,700. So it makes a lot of sense that a pay-for-performance program would be very effective in this kind of scenarios, because the amount of money I have to give the agent to make them switch an action that's way better for me is not that much, right? On the other hand, if the physician was also getting reimbursed kind of a large difference, then they wouldn't change their action regardless. Does that make sense? Okay. So what does this mean for existing Medicare policies? So this gives us like some immediate insights into how the Medicare policies should work. So first, if you look at the readmissions and the existing Medicare policies, two of them, the readmissions and the hospital-acquired condition programs, only offer a penalty. So if you do really well, you don't get anything. And if you do badly, you get a penalty. Whereas the value-based purchasing program offers a bonus for good performance and a penalty for poor performance. So part of the kind of debate that the Agency of Healthcare Research and Quality represented was that when they were designing these programs, they weren't sure if they should just have a penalty or also have a bonus. So having a penalty is kind of a win-win for Medicare because either you improve, which is good for them, or you pay the penalty, which is also, money that comes back to them. But then if you have a bonus, there's this risk that you might actually have to pay out some money, and maybe, it doesn't actually end up helping that much. So this is what the readmissions reduction mechanism looks like. Basically, the x-axis here is like the performance metrics, so how many readmissions you're getting per hospital. 0 is kind of the average performance across hospitals. So the program is structured such that if you do better than average, so the y-axis is the pay for performance adjustment. So if you do better than average, you get 0. So you get what you would normally have gotten. And if you do worse than average, then you gradually get less until you get up to a 3% penalty. And below the 3% penalty gets capped. They don't want you to go out of business or anything just because you have a lot of readmissions. So there's only a penalty. You can only do worse under this program, right? So if I were to add a bonus and make this look more like the value-based purchasing program, I would just kind of make it symmetric. So now, if you're above average, you can get up to a 3% bonus in your payment, and then it's also capped similarly. Right. So this is clearly more expensive for Medicare because these guys they'd have to actually pay them a bonus, but then possibly they would reduce readmissions and things would be better. The argument they made was if they're already above average, why bother paying them? They might not actually get any better. Okay, so we tried plugging this into our theorem. So you can actually cast the Medicare current penalty-only policy as phi naught is just a piecewise linear function. And then you can cast this new symmetric bonus penalty policy that's more like value-based purchasing as phi 1. And you just plug in to see which one's better, g of phi 0 or g of phi 1. And here we immediately get this result that having a bonus is only better if and only if that ratio that I mentioned is less than about 0.45, right? So this is, again, the variance in kind of the agent's preferences versus the variance in the Medicare's preferences. So to give you actual numbers, we looked at some existing papers. This one in particular is from my co-author. So if you looked at heart failure readmissions, which was one big focus of this policy, the hospital has the choice to kind of do an intervention on a patient to reduce their likelihood of getting readmitted. And typically an intervention will cost $1,000. They have to get a nurse to call the patient, maybe make sure they're adhering to their medications and stuff. But if they did get readmitted, the cost to Medicare is about $14,000. So here, the variance in cost to Medicare is huge because it's $14,000 versus possibly nothing, weighted by some average probability that the patient will actually come back, which is about 30%. But the cost to the hospital is not that large; it's about $1,000, right, versus nothing. So in this case, this ratio is actually quite far below 0.45. So it actually does make sense to add a bonus because the bonus will get those above average physicians to also invest in doing interventions, and hopefully that would reduce readmissions rates. And because readmissions rates are so costly to Medicare, it actually makes sense for them to invest in this. Okay. So this is nice in the sense that we're not trying to prescribe an optimal contract or anything. Because they already have kind of very strict ideas of how these contracts should be designed, right? They want the cutoff, they want it to be gradual, and so on. And all we're doing is offering a tool with which they can immediately answer these kinds of design questions that that are very restricted that they've already decided upon. Okay. Does that make sense? Questions? Okay, so just to take another example, another question that came up in the same debate in the Agency of Healthcare Research and Quality was, should we have a single performance cutoff or should we have a continuum of cutoffs? Right? So as you saw in the readmissions program, the actual performance-based modifier kind of scaled linearly. Like it was a piecewise linear function with sloped. So as you did better, you got more and more money up to a cap. Right? It turns out behaviorally that's not a great idea to do because it's not very interpretable to the physicians. It's much better if you have a step function type of function. So I just think, oh, there's a single cutoff. I want to be above average, and that's it, right? And then they can that actually is a specific number to them. So on their day-to-day operations, they actually know what they're targeting, as opposed to this linear thing, which Medicare will calculate for them at the end of the year, and they don't really know where in the spectrum they stand. Right? But people thought having a continuum of having a continuum, making it gradual, would incentivize more people, because if you're on either end, you still maybe have some region to improve. If it's a cutoff and you're very far from the cutoff, you might think, oh, well, I'm so far from the cutoff, what's even the point of me trying? So what they ended up doing was, for the HAC reduction program, they kept a single cutoff, and for 2 of the other ones, they kept a continuum, right? Because they couldn't really decide which was better. Okay, so now we can try the same thing here. So the HAC reduction program looks kind of like this step function. So here 0 is going to be the bottom quartile, not the average. So if you're in the bottom quartile, you immediately get hit with this 1% penalty. And if you're above the bottom quartile, then you get nothing. Right? So this is the current policy. If I wanted to make it look more like readmissions, I would do this. So I would kind of smooth out this step function and make it kind of gradual linear piece. And it would still be capped in the same place. And I've basically made sure that the volume under this curve is kind of the same, so that the amount of penalty that I'm giving to all the hospitals is preserved. Right? So I'm not making any more money through that. Okay, so we do this. And we just cast it again. So I write down the functional forms of each of these policies, and I plug into our theorem. And again, what we're really trying to decide is trading off between incentivizing more providers versus the size of the incentive. So if you go back to this curve, this is, because this piece is kind of longer, it incentivizes more providers, like basically every provider that's in this region, versus the step function might only incentivize people who are very locally around this point. But of course, like improving a little bit is only going to give me a proportional amount of reward, versus if I were here, improving a little bit gives me 1% back, which is a lot more money. Okay. So surprisingly, here we found that having a single threshold was actually always better than having this gradual slope, which was against the intuition of the people designing these policies, because they thought having a slope thing would have more providers engaged on the policy. But it turns out that this is just because the incentive size is so small. So if you have a continuum, it incentivizes more people, but the size of the incentive is already really small, and now by making it sloped, you're basically diluting the size of the incentive more. So at some point, it just becomes worthless. And this is certainly not true when you increase the size of the incentive, but for the sizes that Medicare is considering, I mean, there's really no point in making it sloped. So this is nice because they wanted to make it a single threshold anyway, because that's behaviorally more amenable. So it looks like you can just have the best of both worlds anyway. Okay, so we think that having this kind of a result is useful for them, just because they can answer these kinds of questions kind of very easily. Right? But then we were looking at this and we thought, okay, let's take a step back and think, what is an optimal mechanism like? Do we always just want to look at small incentives? So we remove the constraint, and we no longer assume that there's only 2 treatments or that the correlation is 0. And we look at a restricted class of mechanisms that are roughly linear. So these are called alpha incentive mechanisms. So now we've actually replaced fee with a functional form for it, and that means we have to actually define what performance is. So we're going to call performance as the difference between what actually happens in terms of cost or patient outcomes versus what would have been the expected outcome had Medicare decided what treatment to give. So Medicare observes X1, or some of the features, and they can actually choose the best looking treatment based on those features. It's probably not a very good choice because they're not observing the information the doctor has. So the difference between the added variation in outcomes should capture kind of the value that the doctor is providing. So this is what we define as performance. Right? So we subtract out the max of X1 transpose beta J1, which is what the Medicare would have contracted on if they had no choice. Okay. And then we define something called efficiency, which is just a ratio between the action that the agent ends up picking, so the utility from that, versus the best possible action that could have come out for the principal if they had perfect information and perfect control. And we obviously want to pick the incentive size that maximizes the efficiency. Right? Makes sense. Okay, so we actually can, because we've assumed a linear contract, now we're more like the existing literature, we can actually derive a closed form for this efficiency. We don't have to worry about limits or anything. And it turns out that this depends on 3 parameters. So first, again, it depends on M, which is the ratio between the magnitude of the agent's preferences versus the magnitude of the principal's preferences. When that's small, then it's kind of more useful to have a pay-for-performance program. It also depends on S. So S is the ratio between sigma 1 and sigma. So this is the magnitude of information available to the principal. So when X1 captures all the relevant information and X2 is not really useful, that means that Medicare knows a lot and they don't need to really rely on the doctor to figure out what the right treatment is. So that's the case where S would be pretty much 1. And the other extreme is when Medicare basically knows nothing and the physician knows everything, in which case S would be close to 0, and then between 0 and 1 interpolates between these regimes. And finally, rho squared over M is the correlation. This is just a correlation of the agent and the principal's utility functions. As rho is close to 0, the agent really doesn't care about what the principal wants, and as it's closer to 1, they care a lot. So using this, we can actually derive the regimes in which a pay-for-performance mechanism is useful, which is when alpha star is greater than 0. So it's useful when rho is close to 0. So that means that the physician doesn't care about what Medicare wants, and so we really need pay-for-performance to align the incentives better. Right? As rho is closer to 1, you can trust the physician to make the best decision for you. And then when you take M is close to 0, so this is when it's really easy to manipulate the agent's actions by just paying them a little bit of money. So this is more like the economist example. They're choosing between $201 and $12, which is nothing. So I'd much rather just pay them that money directly and get them to make what's the right choice for me. And in that case, pay for performance is very useful. And finally, when S approaches 1. So when the principal or Medicare has a lot more information about the patient, they have a much better estimate of how well the doctor is performing, right? Because they can get rid of a lot of the variation. And in this case, it makes sense for them to offer much larger incentive sizes because the variation is small, so the net incentive size is also small. I mean, this just goes back to kind of the whole push that, like, as we incorporate more data about the patient, we can kind of reduce adverse selection and, just make generally more intelligent choices. And that is it. Are there any questions? Yeah.
I may be totally wrong, but I thought that doctors were somewhat salaried, and then the payments went to the hospital as an institution.
Yeah.
So then, are doctors actually responding individually to monetary incentives?
Right, so that's a good question. So a lot of these policies are targeted at the hospital level, but there's a rising trend that doctors are stockholders or actually own a lot of the hospital stock. And so if the hospital makes more money, they make more money as well. Right?
monetarily and not just like doing what's best for the patient
Yes.
all the time. That's kind of sad, but.
So there are several papers about this thing called upcoding, where they would purposely put down worse diagnosis for the patient so that they can collect more money. I actually also have a paper with empirical evidence documenting that effect. And then as far as medications go, like ProPublica has a really great series right now about why treatments cost so much. The Economist example was also based on empirical evidence that, I mean, it might not always be malicious, right? It looks like both treatments are similar for the patient, so why not prescribe the thing that gets me more money? You know, like, why do I care whether Medicare is losing money and pharma companies are making more? And then there's also more malicious settings where there's kickbacks. People get taken to like, we're cracking down on that more. Or by we, I mean the government. So, yeah. Other questions? Okay. So I think there's actually a lot of space for game theoretic analysis in looking at kind of pay-for-performance programs. This is just kind of one small slice of it. There's a growing available amount of data that's available to actually figure out what might be even better policies, or to crack down on which hospitals are maybe committing fraud, and using that information to better tune these policies. So we think just off the bat, we're able to kind of easily provide insights into things that were kind of heavily debated about Medicare policies just by using game theory, because it's not a big area of research so far. And of course, you can always derive analytical expressions for the optimal contracts, and that's also something that is maybe of some value to them in this space. But yep, thank you for listening, and feel free to email me any questions or comments, or take them offline.
We have 10 minutes for questions.
So how much have you been, you might have said at the beginning, but have you been working with Medicare closely on this? Or is this something, like how are you going to connect this information to them as they plan their programs? Or are you already doing that?
So this is something that there's a bunch of health policy kind of talks we've been trying to give them to, so these policies are already implemented, so after a few years they'll kind of review the empirical evidence they've collected so far. But the hope is that, you know, AHRQ will be interested in it. So this paper it's still kind of work in progress. But for example, our paper on upcoding, we actually tried to communicate with them that, you know, these hospital-acquired infection policies are flawed. So what we found there, this is not related, but we found that they have this policy, the HAC Reduction program, penalizes hospitals that for having like kind of high hospital-acquired infection rates, but there are some states where there's a lot of state regulation, and so they're just more honest about reporting their infection rates. And there are other states where there's not a lot of regulation, so they get away with kind of not reporting some of them. And what happens with the policies, because they're using these self-reported rates, they're penalizing the truthful hospitals rather than the low-quality hospitals. So these kinds of policies, because they're so ad hoc and, you know, they just kind of came out and said, let's do pay for performance, might have, you know, very unintended consequences. And these are low-margin firms, so you could really hurt their business. And if a good hospital closes down because it was more honest in their reporting, that's obviously not ideal. And there's a couple other research teams kind of trying to propagate these findings, and they have been slowly thinking about adjusting their policies. So they haven't responded to kind of what we did, but they did include, so there was an issue that they were penalizing readmissions rates, which was one of the issues. And there was some research that came out that said that hospitals with high readmissions rates actually have lower mortality rates. So it's not the case that that's always worse quality. It could be that they're bringing you back in because they're concerned about you and want to make sure you're okay. So now they've added kind of a risk adjustment for that. So, you know, it's the government, so it's slow, but I think they are kind of taking these things seriously because these are new programs, and obviously they're not perfect, so. Yeah. So long answer, sorry.
No, that's great.
Other questions? Yeah.
So you get results for small incentives. So the way I understand it is that there should be like some threshold below which like it's like the results hold. Do you have any like ideas of that? How does it like what is small like?
What is small?
Yeah, could you like quantify like the threshold and how like it evolves?
Right. So analytically, no, but we have a lot of numerical kind of simulations to try to understand what is small. And usually small, so far, so actually that's a good question. I don't know if there's like a phase transition or something where like some incentive size is small. We didn't think about that. We've always been plugging in the numbers that Medicare has. So for us, small is 1 to 3%. Because it's 1% for HAC reduction and 3% for readmissions. But yeah, I guess there might be, yeah, that's an interesting point. There might be some regime in which once you're past that, you don't need to make the incentive size larger. That would be an interesting area for research, right? Maybe you can say something like, oh, once you get to this size of incentive, it's diminishing returns, so don't bother, because they obviously prefer to keep it as small as possible. So I don't know. Yeah.
Other questions? Let's take those